Hi, everybody. My name is Rudin Domi, professor of anesthesiology and intensive care medicine in Faculty of Medicine, University of Medicine, Tirana, Albania. I really thank you, Professor Pujic, for this kind invitation in this traditional and very helpful for us uh, conference, workshop regarding obstetric anesthesia. My topic for today is severe left ventricular outflow tract obstruction in a pregnant woman, a report. Regarding my disclosure, I have nothing to declare. So the major adverse cardiac events are of great importance in a pregnant woman. They are very frequent, and according to data published in European Heart Journal in 2017, we can see that in the first trimester, 5% may be heart failure and ventricular tachyarrhythmia. And in third trimester are heart failure and ventricular tachyarrhythmia, but this in this moment is right up to 40% of pregnant women. So the major incidence is in the third trimester and the first week postpartum. So major adverse cardiac events are of great importance in the pregnant woman that it's suffering from this. Uh, all of us that are working with pregnant women with obstetric gynecology have some principles of, let's say, physiopathology during pregnancy. And three components are very important to us. Hemodynamic changes in normal pregnancy, like the increase of cardiac output or reduction of systemic vascular resistance, and minimal change in mean arterial blood pressure. Regarding changes in ventilation during pregnancy, we may see an increase of minute ventilation by respiratory frequency increased. By of course, this is related by the increased basal metabolism and oxygen uptake by the pregnant woman, and respiratory mechanics from the upright position of diaphragm due to increased intra-abdominal pressure and increased size of uterus. In total blood volume and plasma volume and red cell volume during normal pregnancy, we see a very much increase of total blood volume and plasma volume, but this is not associated with an increase of with the red blood volume. So we face, especially in pregnant women, the so-called physiological anemia. It's not real anemia, but it's associated or linked or due to total increase of blood volume and plasma volume. Mothers are estimated, so pregnant women are estimated to have any type of cardiomyopathy in 1 to 4% of all pregnancies, and during the period of 2013, 2015, in United Kingdom, it's approximately maternal deaths from cardiovascular reasons is 2.4 in 100,000 maternities. There are three forms: hypertrophic, restrictive, and the so-called peripartum cardiomyopathy or dilatated cardiomyopathy. That it's a combination between the clinical features like decreased contractility, decreased output, increased preload, increased pulmonary pressure, and of course the changes during pregnancy, like increase of stroke volume, of heart rate, decrease systemic vascular resistance, vasodilatation, and the modulation, concentric remodulating of heart during pregnancy. In the same article published in European Heart Journal 2017, we see that our role, our duty is in the antepartum period, peripartum, and postpartum. Of course, the cardiologist in the first phase and in the third phase are more important than us, and their role is to monitor and to see how the heart function in pregnant women is. Using thoracic echocardiography, beta blocker for arrhythmia, caution use of diuretics for volume overload, and of course, in the postoperative period, to minimize the risk for developing heart failure during or after the pregnancy. What about our anesthesia approach in a patient with a pregnant woman with cardiovascular disease? There is no consensus between general endotracheal anesthesia or neuraxial, but of course, if gradient is mean gradient is more than 50 mm mercury scale, general endotracheal anesthesia may be preferred. General endocrine anesthesia or technique may be a technique of choice because can avoid a decrease in preload, and using inhalator probably we can profit a negative inotropic effect of inhalator in order to decrease the problem in this kind of patients. Acute preload, that it's be judged by transthoracic echocardiography or by measuring central venous pressure using right internal jugular vein catheter insertion, or and by invasive monitoring of blood pressure. Beta blockers may be preferred because they can reduce inotropism and obstruction. Inotropes must be avoided if not necessary because they can increase inotropism and obstruction. In order to increase the blood pressure after the induction of anesthesia, phenylephrine is preferred because it's a pure alpha blocker and has no effect on beta receptors. And of course, in moment in which we can administer oxytocin, the administration should be slowly in order to avoid the induced hypotension by oxytocin. There are two case presentations for today. The first one is a 29 years old pregnant woman, the first pregnancy with no previous medical history, no cardiac subjective and objective signs, with a normal fetal development. In preoperative anesthetic biochemistry and in our visit, she was okay, but in cardiac pre-op, the cardiologist suddenly uh, uh, unknown for the pregnant woman, verified a severe hypertrophic cardiomyopathy. The first view, ultrasound view, a parasternal chamber short axis estimation demonstrated the thickness of the wall, respectively at septum, respectively 19 mm. The second view demonstrates the gradient that it's 76 mean arterial pressure 76, and the third one demonstrates an increase in pressure in pulmonary artery, that is approximately 24 mm mercury scale. During contractions, mean gradient pressure was 81 mm mercury scale. Anterior mitral left movement is blocking during systole the outflow of left ventricle, and the thickness of septum was verified also again. What about our anesthetic approach? After careful evaluation between anesthesiologist, cardiologist, and obstetrician, we choose general anesthesia for cesarean section by using invasive monitoring for blood pressure, two large bore peripheral catheters. We optimize before the surgery using fluids the preload, and we do not allow hypotension using phenylephrine, and in later moments norepinephrine. The surgery was uneventful. The patient was extubated in OR and then transferred in ICU remained there for the next 24 hours. In ICU, we again reevaluate the patient by obstetrician, cardiologist, and from us. And oxytocin we administer very slowly in order to avoid hypertension. But according to our practice in this case, we stopped oxytocin because oxytocin was able and dramatically increased the gradient. After oxytocin stopped, the gradient was as pre-op, and the patient after that was transferred in obstetrician ward. The second case report for today is a recent one in June 2025. Was a patient with a second cesarean section. She was operated in Turkey in the age of 5 years old. They substitute mitral valve and then they put a mechanical prosthetic valve prosthesis. After that, during the patient who was growing up, there was a modulation of left ventricle, who is very small, and significant enlargement of left atrial under, of course, under her coagulation, under tracheomarine. But the patient was referred to us 1 week before the approximately estimated delivery time because the patient has vaginal bleeding and was verified an international normalized ratio 8. So octaplex and fresh frozen plasma was administered. After that, the patient had an international normalized ratio 2.6 under general anesthesia, and radial artery was cannulated. After that, we just administer antibiotic prophylaxis. The patient was extubated in OR and transferred in ICU for 24 hours for monitoring. These are the views from echocardiography of this patient. And these are the views from the monitor of the patient and from surgical aspects and moments during the procedures. What are the key messages for us for today? During pregnancy, cardiac disease may often be faced. Cardiac disease signs may be hidden by pregnancy symptomatology. Careful and multidimensional examination is mandatory, and mother takes always, of course, the priority. I really thank you again, Professor Puig, for the invitation. Thank you for attention, and I'm very anxious to have your questions and to have the right answers for your questions, or let us discuss between each other our experiences between different countries and different institutions. Thank you very much. Thank you very much for this opportunity.